Share the presentation.
You're live now. You're live.
All right. Good morning, IYC family. This is day 3 of the International Youth Conference. And what better way to start off the morning than with a wonderful panel on health? My name is Khadija Kamara. I'll be the moderator of today's session. So we have 2 very esteemed panelists joining us, and we have 1 or 2 other panelists that will be joining us that are running a bit late. We have Mr. David Oye and Dr. M. Nadim Zafar. So to start off our session, I would just like for you all to briefly introduce yourselves to our audience before we talk more about the themes of this session. So we can start off with Dr. Nadim when you're ready.
Thank you so much. Yes. Distinguished dignitaries and the people around the world, good morning, good afternoon, and good evening. You people are doing great. And first of all, I would like to thank United Nations for organizing International Youth Conference. Yes, empowering youth to achieve the Sustainable Development Goals from discussion to innovation, inclusion, and action. Yes. Okay, so thank you so much for having me. I'm Dr. Nadim. I'm a clinician and an educator by the so this is my pleasure to be here, and thank you so much for the invitation.
All right. Thank you for that introduction, Dr. Nadim. Mr. Oye, do you mind introducing yourself?
Okay, good afternoon, good evening, and good morning, everybody. Distinguished gentlemen and ladies all over the world at this International Youth Conference, the 8th edition. It's a privilege to be here, and I'm so grateful to United Nations and all the other organizations involved in organizing this conference. It is a privilege to be able to deliver a presentation on something that is so dear and important to me at this platform that collaborates with the Sustainable Development Goal, especially Goal 3. My name is Dr. David Oye. I'm a medical doctor. I'm a sickle cell warrior. I have sickle cell hemoglobin SS. I'm a sickle cell advocate and also an author of some books. Thank you very much.
Thank you for that introduction. I'm sure this is going to be a very wonderful panel, given that we have a clinician, and also, Mr. David, just having your experiences are so invaluable. So I'm really looking forward to us getting into this discussion. To start off, Dr. Nadim, do you mind sharing your presentation?
Sure.
Awesome.
Sure.
Thank you.
Yeah. Visible? I just want the confirmation if
Yes, we can see your screen.
Yeah. Okay,
Thank
fine.
you.
So the topic which I have given, this is the promoting inclusivity and accessibility in community healthcare for enhanced health and well-being. First of all, the word inclusivity, yes, this is really important. Meaning is to include everyone, irrespective of caste, creed, religion, and national boundaries. Yes, we are the people of this world and we are the family. And this is our responsibility to bring everyone together for the same purpose, for the same goal. And this is our responsibility to make this world a better place to live. So yes, this is my pleasure that I'm going to speak on this topic. So first of all, I'm starting with the human evolution. We have come a long way, but when we look back at the human evolution, there used to be the healthcare service, right? Healthcare service, there was some infrastructure, not so much well developed, but there was a gap between the people and health infrastructure, healthcare providers. With very less infrastructure, and for the same reason, there was huge mortality, huge morbidities, and slowly we started understanding the importance of a smooth and healthy life. And we started working on improving the health system. This has taken hundreds of years. This has taken hundreds of years to reach here. Hundreds of years, yes. And after that, few more hundred of years to reach, to shift from the black and white zone to this zone, up to the colorful zone, the era in which we are living now. This is 21st century now. Okay, now we are living with very good infrastructure, very good facilities, very good team of doctors. Yes, I can say that we are having the best team, not everywhere. We are having the best hospitals now. The era in which we are living now, we are having the best hospitals, but not everywhere. We are having the best of technologies, but not everywhere. We are having great team of doctors, but not everywhere. So far, whatever we have achieved, yes, this is all because of inclusivity and accessibility. We have started including more and more people, and we have started giving more access to so many people. Now, this is the human right. This is the right of everyone, the healthiest life. Yes, so far we have achieved so much, but still we have miles to go, and still we have to do a lot. So that's why, ladies and gentlemen, welcome to SDG Summit 2023. And let me talk something about Mission SDG 2030. And this topic, I have to speak on good health and well-being. I would like to highlight some of the targets. Like there are approximately 9 targets. Okay, first target which I should be talking about, this is about the maternal mortality. First is what? Maternal mortality rate. We have to reduce the global maternal mortality rate, right? And we have worked hard. See, we talk about 15 years back or 20 years back, yes, huge mortality rate was there. Remember when I show you the ratio here, 3,200 deaths per lakh live births, maternal mortality rate. Now only 211 right now per 1 lakh live births. So actually, I can see that yes, there is a good achievement, there is good improvement, but still 800 women around the world are dying per day. Still, we have to achieve a lot. Next, we have to focus on the neonatal death. We have to prevent the deaths of kids, the babies, newborn babies. Especially when we look at developing countries, deaths are due to basic causes. Due to lack of nutrition, due to asphyxia, pneumonia, diarrhea, malaria. And most of the babies, most of the newborn babies, they are dying before the age of 5, under 5. And when we talk about developing nation, death rate is 15%, 15 times more than developed nations. Still, we have to work here a lot. Because when I show you the survey of 2019, 5.2 million children that died under 5 years of age. And third target, we have to reduce, to decrease the epidemics of infectious diseases, HIV, AIDS, TB, the tuberculosis, malaria, and so many neglected diseases. See, even if we talk about the waterborne diseases and so many other communicable diseases, basically infectious diseases. Remember here, when I talk about HIV, when I talk about 2018, by that time, as per this survey, 38 million people were living with HIV. HIV positive. But inclusivity and accessibility with the modernization in the infrastructure of medicine, infrastructure and the advanced technologies and the development of some new drugs. In 2004 and 5, 2 million people died because of HIV, but in 2019, 690,000 people died because of HIV. So I can say here death rate is decreased by 60%. Yes, this is an achievement. When I talk about tuberculosis, every year death rate is decreasing by 2%. Malaria, death rate is decreased by 50%. Now let's talk about non-communicable diseases. This is extremely burdensome. Non-communicable diseases like CVS diseases, CVS like heart attack, myocardial infarction, angina. And next will be the cancer, substance abuse, especially tobacco, alcohol, and suicide. These are non-communicable diseases, but death rate is extremely high. See, remember here, because of CVS, 17.9 million people died. Because of cancer, 9 million people. Because of tobacco, 7.2 million. Because of suicide, 8 lakhs. Death rate is extremely high, and we have to work very hard. Next, substance abuse. This is the target number 5. Substance abuse, the world, I would say, is infected by substance harmful use. Especially the most illegal substance, cannabis. And alcoholism next, opioid afterwards. If I talk about 2019, 35 million people are suffering from drug abuse. And every year, 2.8 million are dying because of substance abuse. Alcohol consumption, if I talk about 1990 and now in 2017, 70% rate has increased. So substance abuse is extremely common and a challenging part. This is a very, very much challenging part. Next, RTA, road traffic accident. Every year, almost 1.35 million people are dying because of road traffic accident. So here we have to implement so many other techniques also. Like we have to control on the speeding. Most of the people who are dying because of road traffic accident, these people are youngsters. And these people are irresponsible, I would say. Means like we have to implement more rules. Like still we are following so many rules, but in so many other countries, right, it is followed. So many people are on their phone call and they are driving the car. Very much dangerous. They are drunk and driving. Extremely dangerous. Yes, our governments, they are working on this, but still we have to do more. And the target 7, sexual and reproduction health. STDs, sexual transmitted disease, extremely common. Now we have to make our young generations ensure about health, about sexual health. I think we are in the need of giving them more education about sexual life, because sexual life is the most important thing where we have to work. And after that, reproductive health, more education about abortion, about the pregnancy, about the nutrition during the pregnancy. And next target, what we have, 8th target, universal health coverage. Yes, very important, because so many people do not have financial freedom to get all kind of treatments. So many surgeries are there which are very, very expensive, which everyone cannot afford. So yes, like in different countries, the government has taken the action. When I talk about India, here also we have like health mission. As per the Pradhan Mantri, every family can get the insurance of 5 lakhs per annum. And this will be covering the major surgeries, operations, hospital bills, and everything. And 9th target, environmental health, air pollution, water pollution, uses of so many of the chemicals. So yes, we are supposed to emphasize on these of the targets. Thank you so much.
Thank you for that wonderful presentation, Dr. Nadeem. It's one thing to talk about inclusion, accessibility, and it's a whole other thing to actually deep dive into it and break it down so beautifully as you did here, because we need to know what exactly does inclusion look like? What does access look like? For me, I am a public health practitioner, but I'm also a Sierra Leonean, and we're the third most vulnerable to the effects of climate change. We have one of the worst maternal mortality rates in the planet, but it's improving. And it's like, what does inclusion look like in Sierra Leone compared to like another country like India or China or Namibia? So this was really great. I think a lot of us, or I know a lot of us, got value, even me as a public health practitioner. So thank you for that. All right. So I want to transition into more of a Q&A, trying to pick both of your brains a bit more and see, how do you implement these things in your day-to-day, right? Inclusion and accessibility. So starting with you, Mr. David Oye, do you mind giving an example of how you actually utilize or exemplify inclusion and accessibility, maybe talking about a project that you've done, and maybe how you also highlight vulnerable populations or specific themes such as like maternal health or whatever it is in that scenario. So you have the floor, Mr. Oye.
Okay, thank you very much. The area I want to talk about is about sickle cell disorder, because there is so much exclusion for people with sickle cell disorder, people living with sickle cell disorder. Myself, for instance. One of the areas is in the area of health insurance. Health insurance in some of the developing countries does not capture people living with sickle cell disorder because they don't really understand it. And I have been able to make people understand that sickle cell disorder is a chronic, non-infectious disease or non-communicable disease, just like asthma, just like diabetes, just like hypertension. So if you include health insurance for people with diabetes, hypertension, asthma, you can also include it for people with sickle cell disorder. Now, for people with hypertension, you do general investigations and specific investigations to know whether there are complications. And if there are complications, you treat the complications and you put them on regular routine drugs. I explained this. Now, that's the same way for people with sickle cell disorder, because once you do general investigations, we're able to detect where the sickle cell disorder, the sickle red blood cells have affected the organs of the body and manage it. Then you can place them on routine medication whereby they attend their clinic. So the kind of benefit in terms of coverage that people with sickle cell diabetes, hypertension, and other chronic disease enjoy is the same one people with sickle cell disorder can enjoy. So I think the right education, providing the right education to health insurance company, makes them able to understand that it is important to include health insurance coverage for people with sickle cell disorder.
Thank you for that insight. You're completely right? That specific patient population, people who are living with sickle cell disorder, have their own challenges, and even I wasn't aware of that specific challenge in terms of healthcare coverage, and it really highlights the depth of the universal health coverage issue. We need to consider the challenges that different patient populations face. I really appreciate that you highlighted that. Thank you. Dr. Nadeem, do you mind giving your example of inclusion and accessibility in your work?
Especially, yes, ma'am. See, actually, when I was doing my med school, like one IAS officer, he asked me, why you are doing MBBS, why you are into the medical school, right? So what actually you can bring something new in this world. Everyone is going to see the patient. Okay, doctor-patient relation will be there for sure. So that time I had one thing in my mind that, see, ma'am, everywhere, people, the common people, the normal people, the people who are non-medicals, who do not have information about health, who does not know about biological science. Most of the people, they celebrate sports. They celebrate new movies. But I have never seen anyone celebrating the launch of any new vaccine, any new medicine, any new infrastructure in the science and technology. I have not seen the common people celebrating about the new surgical procedure. So what I feel the negative points with us that, first of all, the medical language is extremely difficult. And because of this, most of the non-medicals, most of the people who belong to other departments like mathematics or arts or commerce or history or like business, they do not understand the medical language. So people do not show interest in medicine. They do not show interest in health. Most of the kids these days, even in the developing countries, they know how to use mobile phone, how to use all these softwares, which virus can exploit your mobile phone, which can spoil your mobile phone. But most of them do not know which food is healthy for your liver, for your lungs, for your eyes. So what I feel, we should work more on implementing the education about health, basic biological science. When I talk about developing countries, especially when I talk about my country, India, and some other developing countries, there is a social stigma. See, in the young age, most of the people are not speaking about sexual health life. I think we should start speaking on this. Even in the school, yes, there should be education for sexual health, basic health. So my first concern is to preach the education, especially about biological science, especially about health. We should make the language very, very easy so that everyone can understand. When they can understand, after that, there will be very much easy accessibility. After that, we can include more people. So I want to make medicine somewhat, like in the easier language so that other people, everyone can understand. So first of all, my concern is education, educate the people. And after that, I want to see our leaders to come up. Leadership will be having extremely important role. Yes, the government and leadership. And third point, we have to use the technology so that we can reach each and every corner. So I think these are my thoughts here. Thank you.
You actually spoke on something that I've pondered for so long. How can we effectively communicate, right? We really need to build out health communications, and that's really been emphasized with the recent COVID-19 pandemic. We saw how fast misinformation was able to spread. So we have to combat that misinformation with correct health information. So combating misinformation with information, if that makes sense. Like positive information, just to at least reach a middle ground. I mean, there's so many diseases that can be prevented just through simple interventions, such as educating someone, like, hey, maybe you should wash your hands after using the restroom, can stop the spread. So I really like that you spoke on that. Thank you. So we have another panelist, Dr. Priyanka. If you don't mind introducing yourself and um, also giving us an example of how inclusion and accessibility shows up in your work.
Thank you, Khazrita, for the introduction. Sorry for joining late. I was having some problems in reaching out here. It was a traffic. And as this is the day 3 of International Youth Conference, and this panel is going to be interesting. Hello, everyone. Good morning, good evening, good afternoon, based on your location, to our online audience as well, and to our in-person audience too. My name is Priyanka Chahal. I'm a recent medical graduate from Kyrgyzstan. I'm also the Executive Director of International Youth Conference, and it's an opportunity to be here to speak on this important topic with my colleagues here, Dr. Nadim and David, and thank you, Khazita, for moderating it. So this topic is very important because we need to understand how inclusion and accessibility matters in a community. And as we already talked about in the yesterday panel, it was we talked about basically on this topic too, like how the community is having the accessibility of the proper health and primary health care, right? So I just want to tell you that why inclusivity and accessibility matters in health. So well, it is essential to highlight the fact that, as Dr. Nadeem was also saying, that sometimes education is the lag point in a community, and awareness matters. Then only the people and the population are getting to know that, okay, these are our rights and this is how we are going to get education for the health awareness of. I mean, I'm not talking about specific one, but there are like many factors that the community must have to know, and we had to include, as health professionals, we had to include this whole community. We don't have to see the status, we don't have to see their class, and there are like different factors, we don't have to measure them. So that's inclusion, and we have to include all of the community members, and we don't have to leave behind while we are accessing them some any of the health services. So I also come from India, and we have a good primary healthcare system, like, you know, in the bottom level. But you know, there are many ways to improve this, and I believe that the community medicine and especially the public health leaders, they are needed in this, because they are the ones to you know, they are bridging the gap between the community people, between the common population, and then between the health services. So how they are bridging the gap? They are like, first they are providing the education, they are providing the awareness to them, and they are also noting down their current status, and you know, it's like taking the history and everything. So those health professionals in between, they are bridging the gap between the community, between the people, and then between the health service providers. Let's say, take an example, pharmaceuticals, so let's say the healthcare, right, or hospitals. So there are, I just wanted to share some of the points that you know, I just prepared some. It's like practical steps that we can take to promote inclusivity and accessibility in the health. So it's like the cultural competency training. That's one, because many people have different belief, they have different faith system. So we should have to be you know, taking them in all their faiths into consideration, and we have to, you know, train them, and again, here the volunteers play a great role, the leaders in on the ground, they play a great role. There is another one, the language services. Sometimes, you know, healthcare providers must also know the local language, because no, everybody can't understand Hindi or English, and especially in India we have like so many languages, and I'm just talking about that point of view. Even like we have 29 states, every state is having their own language, so even I myself don't know the language. But what we do, we approach the people, then we collaborate, and then the language accessibility is the most important. Then only how people are going to know, okay, these are the health services and how we have to access them, and everything in terms of health must be you know, published in their own language too. So this is one of the main factor. There is also the physical accessibility in the healthcare sectors, where there are special people too, that to whom we have to provide that. And the last thing is that patient-centered care. So tailor health care plans to individual needs, we have to provide that. We have to consider the economic status too. We have to listen and collaborate with patient, as Dr. Nadeem already mentioned, that you know, the relation between a patient and doctor like must be transparent. You know, I mean, patient had to know how, let's say if I talk about surgery, for example, a patient can be, you know, like afraid of it, and this is also included in this, you know, inclusion, because we had to comfort the patient, we had to tell the patient that everything gonna be fine, because that's like, we call it like physical accessibility of the patient, because that's centered around the mental status of the patient. The patient can get nervous. So these are all the factors, but I just talked about some of the, you know, like the common, these are very common factors. We are all aware of this, even if we are not related to the medical field, not related to the health field. But these are very important, because you know, when I was reading some papers on, you know, health strengthening policies in India and around the world, so somehow I found that in the remote areas, they are having the lack of primary healthcare centers. People have to you know, travel like 50 kilometers just to access for example, just to access a general physician. Let's say if they are having fever, they are just taking some medications by themselves. So this thing, we had to bridge this gap in the developing countries, in the global south, and even at IYC, for example. Why we always say that we are focusing on global south? This is because our focus is mainly to, you know, inspire, like basically we are providing education to the global south people, and we are taking into consideration everything like health, climate, then our diplomacy, then people from innovation, tech. So we are including everything. So health is just one of the focus of this conference too, like in terms of innovation as well. So the last thing that I want to add is that we don't have to talk about just the problems that we are having now. I mean, we can talk about the solutions. We can talk about, like with my colleagues as well, we can talk about the solutions and how to implement the solutions on this field regarding. And problems keep coming. So problems are good when we had to read the papers. Okay, these are the problems we know, but how are we going to solve them? That is the most important thing here. And I believe that even my colleagues are doing the great work on their side. And as you too, we had a great panel yesterday, so I know how the great work you are doing. So thank you for that. So yeah, as the panel is going, we are staying connected. So over to you, Khasida.
Wow. Thank you for those wonderful inputs, because I'm an implementer. I like doing,
Yes.
you said,
You find your gutter. I remember.
yeah, find your gutter, not afraid to get
Yeah,
dirty.
yeah.
And you're giving us practical steps that we can take to actually reach accessibility and inclusion, which is amazing. Thank you for those inputs. Especially when we look at health, right? We know health is a human right.
Yeah.
But unfortunately, a lot of these issues that you talked about, they transcend across health, all spheres of health. We talk about hospitals, we talk about public health. In different pockets, these are the same issues that present. So thank you for giving us those actionable steps. I want to head back over to our panelists over here. Mr. David Oye, if you don't mind, also speaking about practical solutions that we can take in order to reach accessibility, attain accessibility and inclusion. Something I really love about this panel is that we have providers and we have a patient here. So your input is really invaluable.
Okay, thank you.
Okay, thank you.
One of the ways I would say is by patient engagement. When it has to do with design of policies, guidelines, researches, manufacturing of drugs, and so many other things related to sickle cell disorder. It is important to involve a sickle cell warrior. In other words, somebody living with sickle cell disorder. And let the person be informed and gather information from him as regards policies you want to design. For instance, when you want to talk about the use of narcotics and other opioids among people with sickle cell disorder, you need to understand how the pain crisis is like. And I often describe it in this manner. Sorry, I'm getting a... Can that be corrected?
We are able to hear you, Doctor. So David,
okay.
we are. It's okay. You may continue.
Okay. So if you want to understand the pain crisis of sickle cell disorder, just picture in the emergency room 3 categories of people walking in. A pregnant woman in active labor. By active labor, I mean she's having 4 contractions in 10 minutes. Each contraction lasting for 2 minutes. And our service is more than 4 centimeters dilated. With the head of the baby already engaged at the pelvis. At that point, she's in active labor, and the pain is excruciating. Another person is someone with a bone fracture, probably multiple bone fracture, walking into the ER. And then the third category is somebody with sickle cell disorder. If you are going to triage these people, the least they will give concern to is a person with sickle cell disorder. Because the person will not be dramatic. He will not shout. He will not dramatize. He will not be aggressive. But he will be having excruciating pain. And the pain is also similar or worse than the pain of a woman in labor or somebody with multiple fractures. Now, if you don't understand the pain crisis, how it is like, they may be willing to give narcotics to somebody with fracture, but will not give it to somebody with sickle cell disorder because they think he's not having as much pain as possible. Now, for people with sickle cell disorder, before you present to the hospital, you will have tried every therapy at home to prevent the pain. And when it has failed, you now go to the hospital. So you're trying at home in the hospital hours, days, and you're already exhausted. No more energy to dramatize, to shout, to grow. And that's when you present to the hospital. So if they're going to design a policy for the use of narcotics or any form of drug for people with sickle cell disorder, they need to engage people with sickle cell disorder so that they will describe how the pain is like before they can put an embargo or a ban on the use of narcotics and other opioid medication for people with sickle cell disorder. Also, in terms of policy, in terms of whereby people treat those with sickle cell. Hello? There has been a problem. Okay. Whereby they think people with sickle cell do not have the same crises, symptoms, and complications like people with sickle cell anemia. But I have reached out to some people with sickle cell trait, and they've described that the same kind of crisis, the same kind of symptoms and complications we do have is the same thing they have. Now, if you're going to do a research, it's also important to involve people with sickle cell trait so that I can help to change that narrative, because I still hear health practitioners, health workers, policymakers saying that people with sickle cell trait are asymptomatic. Most of them are not asymptomatic. I've interacted with people with
Mr. Oye, I think. Yeah, Mr. Oye, I think we lost you there for a second. Mr. Oye? All right. So, yeah, Mr. Oye, I think we lost you there for a second.
We may proceed with Dr. Nadine.
All right. Awesome. Thank you. Thank you for that example. I really appreciate how you're able to visualize the pain crisis for sickle cell patients, for all of us, because that's what we talk about in terms of inclusion. We may not have that lived experience, but we can at least try to understand. And I really like the point that you brought up about not making decisions for us without us. So really trying to partner with the intended patient, but also understanding the patient journey. As you mentioned, by the time a person living with sickle cell has gotten to the hospital, they're already exhausted. It doesn't mean they're not in pain. So that takes a lot of dialogue such as these. So I really, really enjoyed this conversation. I think we're wrapping up the conversation.
No, we are still having some minutes, so we can proceed by more discussion. Perhaps Dr. Nadine, or David can join later.
Yeah. So we're coming towards the end of our conversation, but Mr. David. Awesome. We got you back.
Okay, thank you very much. Sorry for that interruption. Now, I was talking about patient engagement. I've talked about access to care, whereby the use of opioid. Another thing to look into is what other medications do we have aside from hydroxyurea for people with sickle cell disorder? Now, let us look at researches. Most of the information we have about sickle cell disorder are outdated, obsolete, or incomplete. Because while I was in medical school, even up to my period of practice, I was told that people with sickle cell trait are asymptomatic. They do not experience the same kind of crisis, complications, and conditions like people with sickle cell anemia. But my interaction with people with sickle cell trait from different parts of the world, UK, Zambia, Canada, Africa, Nigeria, have shown that there are many people, even here in Saudi Arabia, Jizan, there are many people with sickle cell trait that experience the same kind of symptoms, crisis and complications, the pain crisis, acute chest syndrome, bone complications like avascular necrosis, chronic leg ulcer, stroke. They are also experiencing that. So there is a need for us to upgrade the information we have, and that is why we need to talk about research. And such research also have to involve people with sickle cell trait, whereby we can engage in, rather than a quantitative research, a qualitative research to explore new data, new information regarding sickle cell disorder. And that can help us change the narrative that says that people with sickle cell trait are asymptomatic. That narrative is absolutely incorrect, because we've met many people with sickle cell trait that are not asymptomatic. They had pain crisis, they presented in the hospital, but because the doctor managing them believed, based on what he was taught, that sickle cell trait are asymptomatic, refused to administer care to them as if they have sickle cell anemia, and just gave them a milder analgesic, and they went back home in pain. So those are another area whereby we can bring about inclusivity for people with sickle cell disorder. Other areas are community, in the area of career, they suffer discrimination, relationship. People are not well educated, and so you easily hear this biased relationship. If you have sickle cell, if you have sickle cell anemia, or if you have sickle cell disease, and somebody gets to know, they immediately stop the relationship because they don't understand what it is like. They don't understand how people acquire sickle cell disorder. And so they feel, oh, once you have sickle cell disorder, it's a death sentence for you. And so all of these biases affect every life of people with sickle cell disorder. And that is why you need to include every form of governmental intervention, people with sickle cell disorder, every form of governmental information to change the narrative.
Thank you. Yes, thank you, David. We really appreciate those inputs. Mr. Nadim, can you talk about challenges that you've faced in actually, being a champion of these inclusion and accessibility approaches, especially being a clinician?
Yes, ma'am. Thank you so much. So first of all, I would like to give some of the options which we can try. Actually, what we are practicing in India right now also, but I think there is more need of this kind of work. So first of all, there should be the proper interconnection between the primary health center. After that, and then after that, there should be the proper connection between the tertiary health center. See, actually, what is the most important problem? What I see in developing countries, like especially among village people, especially among local people. Here, what is happening here? Most of the people are not aware about the health insurances. They are not aware about the facilities given by the government also, right? So how we are going to make it better? So first of all, we are going to interconnect the local people with the leaders, and the leader should be accountable with hospital facilities. Local people should be made aware about the insurance, about the health facilities and all. See why I'm emphasizing on this more and more, because I have villages where people are not educated. Because when I talk about my country, 64% people are living in villages and many people are not educated. So they are not very much comfortable in meeting the doctors. Suppose if they are getting a fever, only fever, so they think, like this is very normal fever, this is just the physiological, no problem at all. And just after 5 days, what will happen? There will be what deterioration of situation. And in the beginning, they were thinking this was just a common fever. No problem at all. We can only paracetamol, and like in villages, some other people can suggest them high dose antibiotics, which were actually useless. And when they are reaching the hospital, when they are losing the consciousness, when they are reaching the hospital, by that time it's very, very much late. And when they are reaching the hospital, now they are getting diagnosed by dengue. Oh my God, this was dengue, where there was fluctuation of blood pressure, destruction of platelet counts. So basically here, people are also not educated. People are understanding that simple fever can be very, very much dangerous. This can be very, very much injurious. So yes, at this point, there's the need of bringing out local people into the hospitals. So what we are practicing in India right now, this is called as ASHA worker, accredited social health act. This is actually a community health worker employed by the Ministry of Health and Family Welfare, and this is a part of India's National Rural Health Mission. where they are able to integrate the village people, the local people with health sector. Apart from that, we should be able to reach up to the villages, up to the local people, where at the right time we should be able to screen the diseases. HIV, hypertension, diabetes mellitus, respiratory complications, COPD. I have visited so many villages where I have seen many patients, but like patients are thinking, no doctor, this is a common thing, no problem at all. But when I saw them, when I did the diagnosis, they were suffering from serious diseases. So I feel that this is really, really important to make them aware about the medical thing, about the knowledge right now. And at the same time, right now, the most important challenge, what I feel, this is substance abuse disorder. Everywhere, across my country, across the world, substance abuse, very to all the kids, very access to everyone. And I feel this is the major challenge where I want the leaders to come in front, to implement more laws. And I would like to mention of everyone to make the local people and the hospital more integrated. Thank you.
All right. That is definitely a great point to identify that diseases get worse, right? The more it's left untreated, the worse it can get. So really getting in early with that education component that you discussed earlier, emphasizing the need for health communication. We talked about a digital approach, but using that human-centered approach with the incorporation of community health workers, the integration of community health workers, and really using that to bridge the gap between clinicians and patients is so important, because there definitely is an undeniable gap, as Mr. David Oye mentioned, as all of our panelists have mentioned. And so that was a really great actionable step we can do, because a lot of people in rural sectors, depending on the area, are really, really vulnerable. And a lot of the times, in a lot of rural communities, they're farther away from health access. There's greater challenges in achieving great quality healthcare and accessing healthcare. So thank you for those points. So back to you, Dr. Priyanka. I'd like to learn, what are some challenges that you face in terms of being a champion of inclusion and accessibility? And maybe if you can touch on how you think we can solve for those challenges.
Well, there are several challenges, and I'm a person that I don't talk about challenges much, but because challenges are always there, and it's just not like health disparities or all, but challenges are always there in every field. Even most of our in-person and online audience are also agree on this statement if I say that challenges are always there, right? Agree. So we talk when we have to talk about challenges. Let's talk about the solutions too, because we can't run from the challenges, and they are here for our growth. So even when I started my advocacy when I was in a second year of med school, right, and how I felt different was that because when we approach some health leaders, there are some good, there are some they're also good, but they don't want to support us. So just not because we don't have experience. The first thing they say that, oh well, this is so young lady, I mean, this is not having any experience, so what's she gonna do? But I think that's that doesn't depend on the age and how young or old we are. That depends on how we are having the mindset. And there are several challenges in implementing many advocacy programs. So like right now I'm serving as ACL ambassador. That's the Association of European Cancer League. It's a European Union project. So I'm serving as an ambassador for that. So The challenges in this field as well is here. For example, if I have to, collaborate with different students, it's okay to convince the students, but it's not so easy to convince all the health leaders. Let's say if I'm having any paper, let's say if I wrote any paper, if I'm having any statement, and we are having the views of, like, young people on a paper, and if I have to present to the leaders, so it's not easy to convince them, even if we are thinking, okay, that's good. That's the big challenge. The second challenge I'm talking about is the community access that I already talked about, the access to the health at the primary care center, the access to the health in remote areas. My colleagues already mentioned that this is a big challenge, especially for the women's health. I mean, I myself belong to a very remote area in India, and I know the things they are happening. The women are not able to even access. That's also the big challenge. Let's not talk about this, but let's talk about, because we can talk about challenges when we are not able to do anything. I mean, I'm not calling myself having the mental disability. At least I have a brain. At least I have a thinking power. So I must have to process my thoughts in a way that how I can implement the solutions regarding these are all challenges. All the challenges are written in several papers, several research papers we are having, not just the health field, like all of the related fields in health. Let's say organizations, NGOs. Then we have the pharmaceuticals. Then we have this with the hospital administration. Then we have everything. So challenges are written there. You can just read them, but let's talk about and writing about the solutions, and especially in the practical field, like how we have to go into the war, and we had to win the war. So let's talk about having the strategy to win this war of, like, finding solutions of the challenges. So this is a very important topic that we talked today, and I think we have to wrap up. So I'm not even going further to take more minutes. And I just have this last thing to say, that inclusivity and accessibility are not just moral imperatives, right? They're not just the moral imperative that we just keep thinking about that, but rather than that, they are the fundamental to achieve the better health outcomes and well-being for the community, for the people. And we have to take some practical steps too, as we already talked about that. And then we can create a healthier healthcare system for all, leaving no one behind. And then we at IOC keep talking about this, that we leave no one behind. So in health as well, it's the same. So let's foster a healthier society. And I would like to say thanks to my colleagues here, that I'm so honored to share this platform with these great people here, and with you, Kasida. So over to you, as we are about to wrap up. So
Yeah. Wow, this has been such a powerful panel. As you mentioned, you talked about support. You talked about partnerships. All of our panelists have talked about partnerships today. And it's really important that we think about health, not just in the bubble of health, but that we live in a greater ecosystem, right? Health is impacted by other intersectional variables, like our environment. So do we have an environment for inclusivity and accessibility? We can have the champions, but do we have the partnerships to empower these individuals, these change makers, these champions, to actually actualize change? Those are really great points that you brought up. So as we wrap up, I want to give each panelist just one sentence that you can leave our audience with. What's your takeaway message in terms of inclusion and access before we take one or two questions from the audience? So if I can start with you, Dr. Nadeem, what's your takeaway for us?
Yeah. See, I would like to suggest here there should be maximum access to healthcare.
Awesome.
And especially the doctors who are working at the primary level, please keep on visiting the local people, screen the diseases on time, reduce the morbidities and reduce the mortality rates, and spread the education in easiest local language. Make the medical language very much easy and enjoyable, so that everyone can understand and everyone can have very easy access to medical part.
Thank you. We need to maximize and localize. Localize in terms
Yes,
of
ma'am.
location and our content. Thank you. Mr.
Thank you.
David Owoye, what's your parting thoughts for us?
Okay, my
Okay,
parting
my
statement
parting
is based
statement is based
on one of the
on one
myths
of the myths
within the
within
cultural
the
and religious
cultural and
setting
religious
about sickle
setting
cell
about sickle
disorder,
cell disorder,
Mm.
where people think
where
sickle
people
cell
think sickle
disorder
cell
is
disorder
due
is
to
due
demonic
to
or
demonic
satanic
or satanic
influences.
influences.
My statement
My
is this:
statement is this:
the presence of
the
sickle
presence
cell
of sickle
disorder
cell
in us
disorder in us
is not the
is
absence
not
of
the
God in
absence of
us.
God in us.
Thank you.
Thank you.
Such a powerful statement. We need to destigmatize, we need to educate, and we need to better communicate health ideas and health truths. Thank you for that. Dr. Priyanka, what's your parting thought for us?
Thank you, Kasida. Well, let's just focus more on the solutions rather than challenges, as I already spoke about. And you know, public health and global health is a very, very wide area. So you must have to know which area you want to choose and where you want to create the impacts and what makes your fire, keep burning from inside. So that's all. And if any of our participants, even at we have like many IOS ambassadors, so anybody who is interested in health research and health projects, so feel free to contact me as well. Feel free to contact our colleagues as well. We are always happy to connect you all with our panelists too. So as we are wrapping, and I just want to make sure to for our online audience and in-person participants too, that just please stay tuned with us. We are going to have more panels back to back now, many interesting panels. And thank you everyone for joining us today. It's a pleasure to be here. Thank you.